Right, it's great to see so many of my colleagues on one platform, however virtual it may be, but it's always nice to see everybody. So thank you, ENDIAB Summit, for inviting me. Thank you, Sanofi, for funding it. And a special thanks to my friends Shomobroto, Onirban, and Deb Mallo, who perhaps encouraged me to attend the Child's Best update sessions. So what I'm going to spend on the next 15 to 20 minutes is the use of sulfonylureas, particularly the safe and smart one, the second generation one, and focus on the basal supported oral therapy. So on top of basal insulin is what I'm going to really talk about. Thank you for those kind words from Obratos. I'll skip my introductory slide. So I'll start with the case. We'll look at the safety and efficacy of modern sulfonylureas in the management of diabetes and some insights into its extrapancreatic effects. We also look at the advantages of combining modern sulfonylureas with insulin and finish off with some key takeaways. So the case is run-of-the-mill, very practical, 51-year-old lady, type 2 diabetes, follows up irregularly. The last visit was about 6 months ago. She's on a fixed dose combination of metformin and Glimepiride 500 and 2 milligrams twice daily and vildagliptin. So she's on 3 drugs, a nearly full dose. She can't tolerate a bigger dose than 500 milligram BD of metformin. She's asymptomatic. The review of her symptoms is unremarkable, but she has perhaps lost about 1 kilogram in weight since last seen. She's hails from a middle-class family. Originally, she was diagnosed to have diabetes about 5 years ago with an A1C of 8.9%. She had some weight loss at that time as well with random blood sugar of 276. 6 months back, the A1C was 8.8. She comes in with a weight of 61 kilograms and a BMI under 23. Her fasting sugars have been around 200. And despite she being on 3 oral agents for diabetes, her current A1C was 9.3. Obviously, you don't get any prize, essentially, for deciding that you need to start a basal insulin in this lady. She will need insulin. That's what all the major organizations say. The ADA 2021 does the same thing. The AACE 2020, as well as the IDF 2017 guidelines, essentially recommend to start with basal insulin. Here in India, perhaps you may think of using pre-mixed insulins in some patients, but I think largely we are also coming around to the idea that starting with basal insulin is perhaps an easier and a prompter way of adding insulin to our patients with type 2 diabetes who are actually suffering from secondary failure. Does she need to continue oral agents? I think the dictum now is that perhaps they should. And the OADs which you should choose such that the efficacy and safety is well known so that it benefits our patients. So the clinical challenge essentially is which OAD to choose so that there's maximum efficacy and perhaps even a rapid lowering of blood glucose. Can sulfonylureas be continued along with insulin? Because there's this struggle about perhaps you having more risk of hypoglycemia when you're using insulin in patients with sulfonylurea. What does the data suggest, particularly with basal insulin? Then which sulfonylurea, if you have to choose, would perhaps result in minimum weight gain and hypoglycemia? And then what are the benefits of sulfonylureas with insulin? So should OADs be continued when initiating insulin therapy? I think there's no doubt we should, because it gives you better A1C reduction. It lowers your daily insulin requirements. Okay, so that's extremely important. The oral agents do have comparable effects in terms of glycemic control, at least up to a certain stage, till your patient actually needs prandial insulin. And there are good effects on weight gain and hypoglycemia when you're using basically oral agents in diabetes. From my point of view, if I look back, I look at oral agents having insulin sparing properties, okay? That perhaps saves you on the amount of insulin you need to give your patient, in a patient particularly with type 2 diabetes. And something which I have learned while working on the ground, and I'm sure this is not different for most of my colleagues, including my senior colleagues and professors, that it saves you the embarrassment of worsening glycemic control if an OADs are discontinued inadvertently. So somebody with a fasting of 200, PP of 300, hypothetically, you put them on insulin and you stop their oral agents, for all you know, you'll be surprised when they come back to see you in 2 weeks' time that their fasting sugars and PP sugars have gone up because of the fact that you have stopped their OADs completely. Remember that the OADs do have a role to play on board, and then because we are also initiating insulin on lower doses, you may be surprised and find somebody having sugars which are high. So it can be fairly embarrassing. So there is robust clinical evidence which supports the combination of insulin with oral agents to improve glycemic control. Now, this is Garber's paper, Dr. Garber's paper. This goes back, say, perhaps quite a few years, which makes tall claims of some of the oral agents. But since then, we have got new oral agents in clinical practice. And I think, yes, you can perhaps achieve, facilitate the reduction in insulin dose, improve insulin sensitivity as well as insulin resistance per se, minimize weight gain. In fact, with certain drugs, newer drugs, you can even result in some weight loss in patients with diabetes on insulin. There is also a reduced risk of hypoglycemia with newer drugs. The conservation of beta cell function is a tall claim, and I think most oral agents will fail there, including all the other injectables as well. But if you look at glucotoxicity, if it is addressed, maybe you should be able to at least halt the deterioration of beta cells, which may happen fairly rapidly. So the improvement of a physiological insulin in terms of endogenous into the portal circulation is something which only sulfonylureas can do, okay? When you're injecting a subcutaneous insulin, it is always systemic. Only sulfonylureas or glinides actually result in insulin in the portal circulation, which is truly physiological. So let's look at the safety and efficacy of modern sulfonylureas in the management of diabetes and some insights into the extrapancreatic effects of sulfonylureas. This slide, I'm sure many of my colleagues have seen. Sulfonylureas are good, modestly powerful drugs, oral agents with lower A1C, anywhere between 1 to 2%. The others perhaps fall short. A close second may be, in today's world, SGLT2 inhibitors, which does not seem to find a place in this slide, but anywhere between perhaps 0.7 and 1.3 or 1.4%, you can have a reduction with other benefits as well. But sulfonylureas stand tall with respect to lowering A1Cs. Now, there was an issue about safety with sulfonylureas. And this has been going on for decades. But since the FDA mandated that there should be cardiovascular outcome trials for all new drugs, sulfonylureas again became suspect as to should they undergo a trial as well or not. There have been indirect evidences that the newer drugs were reasonably safe. So in 2018, the South Asian expert opinion was that modern sulfonylureas are preferred over conventional sulfonylureas in patients with diabetes and cardiovascular disease. And in patients with mild or moderate renal impairment, also these perhaps reasonably long-acting modern sulfonylureas can be used, okay? But if patients have renal failure, you may even choose to use a short-acting sulfonylurea like Glimepiride. All in all, there was a suggestion that perhaps the newer drugs are safe. And that actually truly comes from a very important trial, the Carolina trial, okay, which essentially looked at head-on between linagliptin and Glimepiride with respect to cardiovascular outcomes. The DPP4 inhibitors, which linagliptin is, has shown in many trials to be cardiovascularly safe. Okay, so with linagliptin also being cardiovascularly safe. And then Glimepiride pitted against the linagliptin showed that the 3-point MACE as well as the 4-point MACE outcomes very close to 1. Okay, so the risk for cardiovascular mortality or overall mortality was no different in any of the two groups. Again, hinting or suggesting that perhaps Glimepiride as a sulfonylurea, modern sulfonylurea, second generation one, perhaps is a cardiac neutral and there's no risk with respect to the using sulfonylureas in patients with diabetes for many, many years, as well as those on insulin. Where does this fear of sulfonylureas actually come from? And you have to go back in time. The UGDP is the first study, perhaps it's in the early 70s, okay, where tolbutamide was used as treatment for diabetes. While it managed to lower blood sugar, unfortunately, in the treatment arm, there were more cardiovascular deaths. There was a problem there at that end, how the trial was conducted, but during that time, a generation of doctors perhaps felt that treating diabetes with sulfonylureas was no good, and perhaps treating diabetes should not be done. You should perhaps let patients' blood sugars run a little bit high. However, we are much wiser since the UK-PDS study and its results, but none of them have been truly cardiovascular outcome trials. The ADOPT study looked at glycemic control and basically sustainability, okay? Again, not looking at cardiovascular outcomes. There was a hint of cardiovascular outcome in terms of advanced study, which was cardiovascularly neutral with the use of glycoside XR. With the UK PDS, again, cardiovascular neutral with the use of, say, glibenclamide, but the numbers of patients were small. With the TOSCA IT study, pitting sulfonylurea glimepiride against pioglitazone seemed to have perhaps no major adverse cardiovascular events. And the Carolina study, which I have mentioned to you, DPP4 inhibitors, particularly in ninagliptin, very safe cardiovascularly with so many patients in the cardiovascular outcome trials, and glimepiride looked as good as linagliptin with respect to cardiovascular outcomes. So the ADA, even in 2021, 2020, says that the second generation sulfonylureas are cardiovascularly safe as they have neutral effects on cardiovascular events. But I love this slide, okay? We talk so much about the bombastic, new, expensive drugs, okay, including injectables, the GLP-1 studies, okay, the SGLT2 inhibitors, the DPP4 inhibitors. I'm sure we've attended basically many a Congress and heard hundreds of times with regards to these drugs and what they can do. But if you look at how many patients in the Western world are on sulfonylureas while they are on this trial, surprise, surprise, 50%, up to 50%, okay? So even they use sulfonylureas in clinical practice with type 2 diabetes. So sulfonylurea cannot be booed away. It remains an extremely important part of our therapy. And if you look at the origin data, again, basal insulin, but in these patients were only mildly hyperglycemic. Again, nearly 30% patients were on basically sulfonylureas, suggesting that sulfonylureas are here to stay and an important part of treatment of type 2 diabetes. So what are the advantages of combining modern sulfonylureas with insulin? And let's focus on the glycemic control and the insulin dose requirements. And here is a study from Dr. Lee looking at what adding glimepiride to insulin does. Okay, so with respect to hemoglobin A1C, you have a better A1C reduction with the use of glimepiride on board of insulin. Insulin itself perhaps cannot achieve that kind of better A1C control. And that is in spite of you managing to perhaps use lesser doses of insulin. So in the group A, you're using lower doses of insulin to achieve an A1C, which is 7.3, compared to you using higher doses of insulin in group B and still achieving an A1C of 7.9. And as well as there is also benefits in terms of weight. So this improved glycemic control was demonstrated in this study, though the study is not large, roughly about 25 to 30 patients in each group, but they also showed the element of extra pancreatic effects like the increasing adiponectin levels. Okay, glimepiride has been shown to have effects on the insulin receptor, basically glucose transporters as well. So this is perhaps the advantages of glimepiride as a second generation sulfonylurea, as well as being cardiovascularly safe. And in this study, it showed a reduction in total insulin dose that was required in patients with respect to their diabetes control. Here is another study, again showing you a very similar thing, okay, with respect to adding glimepiride, excuse me, lowers your A1C by 0.6%. additional 0.6%. And it does so by having more C-peptide glucose ratio, okay, it's increased significantly with glimepiride. So you are having insulin secretion, endogenous insulin secretion with these of glimepiride. And these are patients who have got diabetes for more than 10 years, okay? So glimepiride works even in patients who have been having diabetes for a long period of time. Sorry. So with respect to Cochrane database, so it's not one or two trials, these are 37 trials that have been looked at, okay? It's a meta-analysis, both in parallel group trials as well as in crossover trials. And the summary of all these trials essentially is that adding sulfonylurea reduces hemoglobin A1C by an additional 1%, okay, compared to patients taking only insulin as treatment for diabetes. But I love this study because this was done on patients who had basically diabetes for 17 years. Okay, so now in this group, if you see the patients who were on sulfonylurea and an insulin, if they were discontinued the sulfonylurea, their blood sugars start to rise. 17 years of diabetes, okay? The light blue line is higher than the dark blue line, okay? And you can see why that is, because your C-peptide levels are higher in patients with the dark blue line. So even at 17 years of diabetes, the sulfonylurea, glimepiride per se, actually is resulting in endogenous secretion of insulin, and it's fairly physiological because it is secreting into the portal circulation per se. Now, how quickly can your blood sugars come down when you basically add a sulfonylurea to basal insulin? I think it doesn't surprise us that adding glimepiride will give you a much faster reduction of blood sugar, as is demonstrated in this slide. It's no surprise really, but there's just data to show you that that's what happens when you add sulfonylurea to basal insulin. Let's come to our own shores. There is a study from Dr. Bipin Sethi, okay? He's looked at the efficacy of glimepiride as an add-on therapy to insulin in patients with high insulin requirements. So these patients were requiring more than 1 unit per kilogram of body weight of insulin for their diabetes. So it was a prospective randomized comparative study. The duration was 6 months. The group A was patients who were taking insulin, metformin, and glimepiride, and group B without glimepiride. And let's look at that data. So in terms of group A with glimepiride, almost weight neutral, okay, 77, 78 kilograms. A1C, very good reduction in A1C from 9.1 to 7.4. And the insulin dose, no increase in insulin dose, 99, 95, okay? Compared to group B when glimepiride was not used and you're trying to lower their hemoglobin A1C, their weight went up, okay? So there was an increase in weight by 3 kilograms. Their A1C was better, but not as good as in patients on glimepiride. So it had come down only to 8% versus 7.4. And look at the insulin requirements, okay? From 98, it went up to 136 units. Okay, so again, a high requirement of insulin per se. So the addition of glimepiride to insulin is well tolerated by patients. They showed lesser risk of hypoglycemia as compared to treatment with insulin alone. Again, there's a significant decrease in the requirement of insulin when you're using sulfonylureas in this group of patients with type 2 diabetes. So our patient, to achieve better glycemic control, put on 10 units of glargine, okay, on top of her oral agents. No change in her oral anti-diabetic agent, okay, because her sugars were high. I didn't want to reduce, be embarrassed by stopping the glimepiride or reducing the doses, okay, because the risk of having a high blood sugars. The next time around when she came in, she gave me results which are much better. Now I could perhaps roll back on the oral agents. I perhaps generally stick to only once a day glimepiride metformin when I'm using basal insulin. So 2 milligram and 500 milligram in the morning is what I have put her on. After 3 months, again, her blood sugar was reasonably good. So the addition of Glimepiride to insulin leads to better glycemic control, significant decrease in requirements of insulin, and we have looked at data with respect to reduction in hypoglycemia as well as lesser weight gain, vis-a-vis if you are trying to treat somebody with basal bolus regimen, addressing the prandial with basically prandial blood sugars with insulin per se. So you're very high risk of hypoglycemia. So in summary, perhaps which OAD to choose from, so which gives you good efficacy and lowering, which is reasonably fast. Sulfonylurea can be one of them. So don't forget sulfonylurea. Don't be in a hurry to stop it. They are reasonably safe, and you can continue with insulin, okay? And with respect to weight gain and hypoglycemia, there's data to suggest perhaps that those concerns are not particularly true for the second generation sulfonylureas, particularly Glimepiride. So with modern sulfonylureas, more reduction in blood glucose, lesser hypoglycemia, lesser weight gain, and lesser insulin dose requirements. And my key takeaway message is physicians should not delay advancing therapy to insulin. So when you think your patient has failed glycemic control, go for insulin. Okay, do not hesitate. Continuation of oral anti-hyperglycemic agents must be considered when initiating insulin therapy. You must not stop. You can reduce, but must not stop, because you're initiating only with basal. Okay, continue with the oral agents, maybe with a smaller dose if that's it. Otherwise, you may basically be embarrassed with hyperglycemia when your patient comes back to report within a couple of weeks' time. The addition of modern sulfonylureas like Glimepiride to insulin and metformin can be effective in lowering A1C, reducing the dose of insulin by almost 30%. That's what the Cochrane data also has suggested, and reducing the risk of hypoglycemia and weight gain with these modern sulfonylureas like Glimepiride. With that, I stop here. Thank you for your patient hearing.